Hi doctors, day 6 of Focus 30. Today it is very important day. See what are the topics I come up with. See, you can see subcutaneous and superficial mycosis, alopecia, bullous disorders, oxygen delivery devices, peripheral nerve block and spotters. See, can you tell this? Yes, related to alopecia. Okay, what is this? Yeah, subcutaneous mycosis. We'll discuss that. What is this? Yes, this is also related to mycosis. This is a, what is this? In anesthesia, oxygen. Yeah, any intubation related? Yeah, it's Goodell airway. And this is immunofluorescence. So today what I am telling, like 6 to 8 question can be come to NEET PG, and I am damn sure 4 questions will be there. 4 questions will be there for this 2026 NEET PG. 4 questions will be there from this topic. Today's session say minimum 4 topic, and it can go to up to 7 to 8 questions. Minimum 4 questions will come from NEET PG 2026. This is sure short area, sure short question session. Okay, now we will go to the individual sessions. Okay, this is highly important. Please like this and watch it whenever you are free, and please make a notes. If you want note, day 3 में video में link is there WhatsApp group का, please join to the group. Okay. So first I am discussing about the subcutaneous mycosis. So there will be some hints in the question. So we will discuss directly about those two. And sporotrichosis, also known as rose gardener's disease. A gardener, it is an implantation mycosis. He got some thorn prick. So there is a history clincher. So there will be some words in that. Okay. So sporotrichosis or rose gardener's disease, it is caused by Sporothrix schenki, and lesions are nodulo-ulcerative lesion. You can see the lesion. See, you can see the lesion, which is like, see, it's following some area. It's like going through a direction. It's moving like that. Okay. So see, you can see this is like a nodulo-ulcerative lesions along the lymphatics of extremities. So along the lymphatics, it is going. So it's like a nodulo-ulcerative lesions. So this diagram only will give the answer. So in histopathology, there is something called asteroid. You can see a star-shaped body here. You can see a star-shaped body here. Nothing but the asteroid board. So asteroid, all related to something like flowers. Okay. So this is mainly sporotrichosis, or also known as rose gardener's disease, which is very important. One more thing they usually ask is the differential diagnosis of sporotrichoid type lesions or nodulo-ulcerative lesions, which is going through the lymphatics. You can see the lymphatics extremities, it is going up. You can see like that. So the differential diagnosis of sporotrichoid lesions, this include nocardiosis, cutaneous leishmaniasis, tularemia, and atypical mycobacterium marinum. Okay, this is also very important high yield question that can come in our exam also. So differential diagnosis of sporotrichoid lesions is a rose gardener who got prick of a thorn, and he has developed this kind of lesion, which is a nodulo-ulcerative lesion, and this have a histopathology suggesting some, you can see it's like asteroid body. Asteroid is a flower, flower. So it's like our flower. So flower, rose, flower, asteroid body, sporotrichosis. Clear. Now we'll go to the next one. It is our nothing but chromoblastomycosis. Okay. Also known as verrucous dermatitis. Chromoblastomycosis or verrucous dermatitis. So this is by a demacious fungi via vegetative trauma. There will be, in history there is a trauma. A farmer in the land got a trauma, and he developed something like a lesions like verrucous plaques with black dots on the surface. So that is the key. Verrucous plaque means irregular shape, any shape, irregular verrucous shape. So on investigation, there is something like a diagram like this. So you can see something like a copper penny or a coin. Copper penny is known as copper penny or medullary or sclerotic bodies. Or copper penny bodies in the diagram. And you can see the lesions here. Okay, you can see the lesions also here. Okay, clear. So management of chromoblastomycosis is itraconazole. Management of sporotrichosis is nothing but itraconazole. So both are same. So subcutaneous mycosis, we have sporotrichosis and chromoblastomycosis. In chromoblastomycosis, there will be there is a demacious fungi through a vegetative trauma caused by Phonaceae pedrosi and Fialophora verrucosa. These are the examples. These are the fungi. So maybe in the option the name will be like this. So Phonaceae pedrosi, who are walking pedestrian, they'll get this vegetative trauma, they'll get infection. And Fialophora verrucosa, verrucous ulcer, because of Fialophora verrucosa. These two terms are very important, very important. So pedrosi, pedestrian walking, they'll get some vegetative implantation of this fungus, trauma will happen, it will cause fungal infection. Okay, subcutaneous mycosis. Clear? So these are the two important questions frequently asking in NEET PG. And one more thing is nothing but our mycetoma. So already you people may be knowing mycetoma have bacterial and eumycetoma, which is caused by a fungi also. Okay, so mycetoma, it is caused by a fungi, it is known as eumycetoma. If it is caused by a bacteria, it is known as actinomycetoma. And the causative agent of actinomycetomas are very important, which are they? Actinomadura madure, Nocardia species and Streptomyces species, especially Actinomadure. So this is important. This is also known as Madura food sometimes. So whatever. So actinomycetoma, which is also very important, and eumycetoma also very important. And you know what are the clinical features of a mycetoma? There will be tumefaction, swelling, and discharging sinuses through the. So you can see the classical diagram here. In this classical diagram only, it is the classical diagram. You can see swelling here. Some discharging sinuses are there, and granules are there. So these are the classical sign of the mycetoma. Both are in common. And here in eumycetoma, it is black or dark color, and the management through antifungals. But in actinomycetoma, it is pale cream color, and the management of the actinomycetoma is known as Welsh regimen, which can become as a potential question in our next NEET PG exam. So Welsh regimen composed of amikacin and cotrimoxazole. So amikacin and cotrimoxazole, Welsh regimen, is the management of actinomycetoma, which is not a fungal infected, it's a bacterial mycetoma known as actinomycetoma, mainly caused by Actinomadure madura. So this is also very important. The diagram is there, history will be there, and clinical features will be there, and everything is similar. And pale cream color, it is going to actinomycetoma. Black dark sinuses is going to eumycetoma, caused by Madurella species, fungi, Madurella species. Okay, clear? Okay, so these three are important: sporotrichosis, chromoblastomycosis, and the mycetoma. All three are important. Okay, now we are going to, these are the subcutaneous mycosis we discussed. So these are the subcutaneous mycosis we discussed. Now we'll go to the superficial mycosis. This is also a potential question, very important question, regularly asking question. Superficial mycosis. So in superficial mycosis, we have different varieties, and in the mainly important one only I am discussing here. In that, one is Pityriasis versicolor. Second is candidiasis, you know, candidiasis. And third one is dermatophytosis. Okay, so Pityriasis versicolor, candidiasis, and dermatophytosis, these three will be discussing in this module. So name Pityriasis versicolor, variety of color. So Pityriasis versicolor, so it is caused by Malassezia globosa or Malassezia furfur. Malassezia species, globosa and furfur, Malassezia. Okay, here there is something called, you can see the lesion here, see the lesions. They have a classical scale called fine Brani scale. If you have a term like fine Brani scale in the question, it is nothing but Pityriasis versicolor. Okay, and you can see the lesions have hypo and hyperpigmented macules are there. You can see hypo and hyperpigmented macules are there, and scales are there. This scale is known as fine Brani scales. Okay, and most common is our trunk. So image of a bag or a trunk with the hypo and hyperpigmented macules along with fine Brani scales is suggestive of Pityriasis versicolor. So in KH mount, there is giving a spaghetti and meatball appearance. This is also very important. You know, spaghetti and meatball appearance, a meatball appearance. Spaghetti and meatball appearance is seen in in the KOH mount. Okay, so treatment is azoles selenium sulfoxide. If it is systemic, fluconazole. Okay, so you should know the clear history. A diagram of trunk will be there, and Malassezia globus and Malassezia furber, hypo and hyperpigmented macules will be there, and you can see in the KOH mount spaghetti and meatball appearance will be there. This is also very important in superficial mycosis, pityriasis versicolor. So fine Brani scale is very important. So we are going to discuss the different scales in dermatology also today. So next one is very easy and very simple one, nothing but candidiasis. So candidiasis we have oral thrush. It's not a, see, you can see here, this is nothing but oral thrush. So it can be rubbed off. Intertrigo, so in between the skins, joint like here or in the groin, so it is like macerated and it has some pustules also, pus also will be there. So intertrigo, this is a intertrigo. Candida intertrigo. In between the finger cuff fold, it will be there. In between neck, in between the groin and fingers of the leg, it will be there. That is known as Candida intertrigo. And melanoprostatis, that is also radial fissuring around the prepuce will be there. So these are candidiasis. You can see the whitish color discharge, and this is very simple spot. Usually they will ask oral thrush. So candidiasis is also superficial mycosis. Now we are going to discuss something but very important area, highly important area. Question, definitely I am expecting a question in this 2026 NEET. So dermatophytosis. So mainly is tinea infection. See, if you are studying theory, it is in detail, so much is there, but I am just preparing for the exam point of view, which can be come in exam. Highly important question, highly important point. So dermatophytosis, we have tinea. In tinea we have Tinea pedis, Tinea cruris, Tinea capitis, and Tinea corporis, and onychomycosis like nail infection. What is Tinea pedis? Pedis, foot. It's known as athletic foot in the web space. It is the most common. So if you are walking through the rainy season ke baad, you are walking through, you will get some wet, then you will get infection in between the web spaces. This is common, known as Tinea pedis, and Tinea cruris in the groin region, and Tinea capitis in the scalp region, and Tinea corporis in the trunk region. According to the region, it is divided into this. Okay. And for the nail, Tinea corporis and cruris infection, and onychomycosis and also nail plate also can be seen. Okay, clear. So this is just a classification, not that much. This is cannot be come in the exam, maybe come, but not sure. So Tinea capitis in the scalp, this is very important. So every alternate year, a single question from this area is coming. Tinea capitis, and expecting one question from this area this year also. Tinea capitis, which is the tinea infection of the scalp, is divided into inflammatory and non-inflammatory. So we have this classification also important. We have inflammatory and non-inflammatory. Inflammatory, we have favus and chorion. Favus and chorion. And non-inflammatory, we have black dot and gray patch. Okay. Now we are going to see the images, then you will understand. Tinea capitis, inflammatory, non-inflammatory. Non-inflammatory, we have black dot and gray patch, and inflammatory, we have favus and chorion. Now you come and see everything is there, very simple. You can see the images also I kept. It is very important. So black dot and gray patch, both are non-inflammatory, and favus and chorion, which are inflammatory. So black dot, so Tinea tonsurens, Tinea violacum. So this involvement is known as endothrix involvement. Black dot, endothrix involvement. And gray patch, microsporum canis, ectothrix involvement. Usually in the question there will be a term called a pet dog will be there, because microsporum canis, which is a pet. Okay, canis familiaris. Okay, you know what is that. So ectothrix, microsporo ectothrix involvement. Okay, involvement. So that is gray patch. These are non-inflammatory. Black dot, Tinea tonsurens and Tinea violacum, which is endothrix. Gray patch, microsporum canis, and there is a history of pet dog and ectothrix involvement will be there. Okay. Now same favus and chorion. So favus, Tinea scholeni, it is known as cutula. You can see Scutulas are yellow colored. You can see that. Okay, I'll show you. So favors may, you can see something here. See here. Yellowish cup-shaped crust known as scutulas are there. You can see here in the side. Clear? Okay. Kerion. So I told about canis. Similarly, kerion, which is a zoophilic fungi living in the zoo. So here also history of a pet dog or pet will be there. Okay. So it is a zoophilic fungi. So if it a pet dog, if it an inflammatory, it will be kerion. Okay, especially seen in children. So this is Tinea mentagrophyte and Tinea verrucosum. See, very important species of Tinea. Tinea mentagrophyte and Tinea verrucosum. These are very important. And which are a zoophilic fungi, history of pet dog in the house and having a inflammatory lesions. So history of contact with the pet and is a boggy swelling with easily pluckable hair. Imagine that swelling. So you can see kerion here. See kerion, you can see here. See kerion. Okay, so here regional lymph node also enlarged. Okay, this is very important. History of pet dog and everything will be there. You can see the favors here. So favors may yellow colored cup shaped scutulas are there. Kerion, you can boggy and pus discharge will be there. Alopecia, scarring alopecia, easily pluckable air will be there. Clear? This is also important. You can see the black dot of Tinea corporis. You can see the black dot. You can see the gray patch. Gray patch. Okay. Okay. So this is also important. Clear? Clear. So history of pet dog, mostly it will go to the kerion, which is inflammatory, which is a zoophilic fungi, and favors and favors, which is having yellow cup-shaped crust known as cutulas will be there. And gray, black dot and gray patch image. So black dot is easy to understand here. You can understand from here. And gray patch, Microsporum canis, there also some pet dog involvement will be there, but not necessarily should know. You should know for kerion. Okay, pet involvement, boggy swelling with easily pluckable hair, that is alopecia will be there. So alopecia also we are going to discuss next. So this is also very important. Superficial mycosis, very important. Pityriasis versicolor, candidiasis and dermatophytosis. In that kerion, favors, very important. They will definitely ask one question from this area, sure. Okay. Okay. Now we'll go to the next topic, alopecia. So just now we discussed about alopecia. Here there was a term you can see here, kerion, risk of scarring alopecia. Clear? Clear. So now we are going to see about what is alopecia in a single slide. In this slide, alopecia, every 2 to 3 year there is a one question from alopecia. So now we are going to see alopecia. So alopecia is nothing but loss of hair. We know that. Okay, loss of hair. Many people have that tension, loss of hair. So many are, even in doctors also, loss of hair is a very, very dangerous event of life. Okay, that is actually true only. So alopecia, loss of hair, it is divided into two: non-cicatricial alopecia or non-scarring alopecia, cicatricial or scarring alopecia. So scarring alopecia and non-scarring alopecia. So non-scarring, what are the causes of non-scarring? There is no scar. So they may be patchy or diffused or patterned or systemic, whatever. These are non-scarring. In scarring alopecia, which are usually associated with some diseases or infections, you can feel steady from scarring to non-scarring. So in cicatricial alopecia, scarring alopecia, it is associated with the papilloscamus disorder like lichen planus, and granulomatous disease like sarcoidosis, and connective tissue disease like lupus discoid lesion like SLE, you can see, and DLE. So discoid lesion of SLE it is there, lichen planus, sarcoidosis and DLE. So all these three and infections we discussed: Tinea capitis, inflammatory, favus and kerion, both favus and kerion. Now we'll see the favus and kerion. Favus also, hair loss will be there, leads to permanent hair loss if untreated. See, both favus and kerion, inflammatory, Tinea capitis, which cause cicatricial or scarring alopecia. So what are the causes of scarring alopecia we saw here? So scarring alopecia, which is very important: papilloscamus, granulomatous condition, connective tissue and infections. These all are important. Okay, hair loss. Okay. So that is scarring. Now we are coming to non-scarring alopecia. This is also very important. So there is a patchy loss of hair seen in alopecia areata and trichotillomania. What is trichotillomania? One's cutting their hair, pinching it, pulling it and eating. this is known as, this is associated with a psychiatric condition, and they have something in the stomach, GIT. What is that? Comment in surgery ka one trichobazar, correct? So things are connected like that. So trichotillomania, and second is syphilis, non-inflammatory type, like that many are there. So non-inflammatory type of tinea capitis will cause non-scarring alopecia. So patchy alopecia, alopecia areata, trichotillomania. And diffuse, this is a patchy which is seen in alopecia areata, trichotillomania, and diffuse alopecia seen in secondary to stressor events. So this is a highly important, and there is a potential question here. So we know we have hair cycle, anagen, tenogen, there are cycles of hair. The cycles, because of some stressor, there is a problem. So we will see. So secondary to stressor events, it will lead to anagen effluvium and telogen effluvium. So anagen effluvium, telogen effluvium, radiation in chemotherapy causing anagen effluvium. So I will write like radiation into RA, radiation. So R, radiation for anagen effluvium. So secondary to chemotherapy or radiotherapy occurs 3 to 4 weeks. After 3 to 4 weeks. So you had seen a patient with ALL or AML who underwent chemotherapy. He's on some drugs. After 1 or 2 months, he developed this hair loss. So I had a patient, K. Rahul, who had admitted in hematology ward last 2 weeks. He came up with fevers, spikes of fever, and unable to diagnosis. Then peripheral smear suggestive of it's like AML, and flow cytometry is done, confirm. After that started induction phase, then started the treatment for this cancer, so leukemia cancer. So he was very fine. He was 21-year-old young boy who was a second year or third year engineering student. So he went after discharging, he went and he come back after the second. He had lost almost his hair. So within a 1.5 months, he lost his complete hair. So this radiation is known as radiation anagen effluvium, RA, anagen effluvium. Telogen effluvium, nothing but secondary to systemic stress. If you got COVID infection, so I got COVID infection. After 3 months, I got so much hair loss. It is because of systemic stress. Because COVID, pregnancy, it occurs 3 to 4 months. So this area, what I discussed, is very important. Anagen effluvium, RA, radiation, anagen effluvium. Telogen effluvium is post-stressor, systemic stress, COVID, pregnancy, it occurs 3 to 4 months. But chemotherapy related, radiotherapy related, it will take 2 to 4 weeks, 3 to 4 weeks, 1 month. Okay, 1 month. This is also very important. Anagen effluvium and telogen effluvium. Okay. Now we'll just discuss about the alopecia areata, which is a patchy hair loss, is a non-scarring. So here maybe autoimmune disorders are targeting the anagen hair bulb. Because of that, it develops. So we know circular patches of to complete hair loss may happen. So here there is something called characteristic findings, which are known as the exclamation mark sign. Okay, you can see the exclamation mark sign here. So here is the patch of hair loss is happened. You can see the exclamation, some hair exclamation. So see exclamation mark. Okay, and there is a typical question can come for your NEET exam. They will ask the nail finding of alopecia areata. The most common nail finding of alopecia areata is known as fine regular pits. This is very important. When we discuss about papilloscomus disorders, there are some nail changes. We have to know the nail changes. Okay, there is very classical named subungual parakeratosis and salmon. Many terms are that I'm not discussing that. But in alopecia areata, regular superficial pits, fine regular superficial pits are the most common nail change. These are the nail changes which is seen in alopecia areata, which is important. So treatment is localized, interlational, steroid injection, whatever. Okay. So alopecia, which is very important, non-cicatricial, non-scarring. Examples we know: radiation chemotherapy induced anagen effluvium we should know, telogen effluvium we should know because of post COVID or post pregnancy 3 to 4 months के बाद, And we should know cicatricial examples of scarring alopecia. They will ask a mixed question like which is the scarring alopecia, which is the non-scarring among these, which is very important. We should know the alopecia areata, their exclamation mark of hair and nail finding like fine regular superficial pits. Okay, clear. So this single slide for the hair loss alopecia, no need of cycles and all. I didn't kept till now, they didn't ask. We are discussing the most important and most expected question for the NEET exam. Okay, clear. Now we are going to the next topic, very important topic, immunobullous disorder. Every year there is a single question from this topic. There will be a single question, not two questions, three questions, a single question from the single topic of this immunobullous disorder from the derma, like that. So this is highly important to derma. Okay, so we will discuss about immunobullous disorder. You should know the primary, secondary and special skin lesions. That is very important basics. So bulla is one among that. You can see the bullous disorder. I had put some everything in the second slide. You can see everything in the second slide. Okay, first and second slide is very important. See, bullous disorder I had made like this. So these two slides ke baad you are able to score your 4 mark. If you are wrong, you are saving the 5 mark. Now we'll discuss about the immunobullous disorders. So immunobullous disorder, we have pemphigus group of disorders. Pemphigus foliaceus, pemphigus vulgaris. Vulgaris means most common. Pemphigus foliaceus, pemphigus vulgaris. And next one is known as bullous pemphigoid. Bullous pemphigoid. And next one is dermatitis herpetiformis. Dermatitis herpetiformis. Okay, nothing but dermatitis herpetiformis known as IgA. Okay, IgA herpetiformis, whatever. Pemphigus foliaceus and pemphigus vulgaris, these are classical, and bullous pemphigoid have different features, and dermatitis herpetiformis have different features. Now we will classify according to the immunofluorescence or clinical features. We are going to come to the diagnosis. All these 4 names will be there in the options, and you are going to trouble and you will trap in their option. Please listen. So what is pemphigus foliaceus? Crust and shallow erasions on the seborrheic area, no oral lesions. So there is something called desmoglein. Okay, desmoglein 1 and desmoglein 3 are there. Okay, so I can see here. So here pemphigus group, the target antigen is desmoglein 1 in the pemphigus foliaceus, and pemphigus vulgaris, desmoglein 3 and 1 are the target. So desmoglein 1 is located all over the body except oral cavity. In oral cavity, desmoglein 3 is rich. Okay, so in pemphigus vulgaris, desmoglein 3 and 1 are the target. Just for understanding, I'm not telling the concept. Please understand this. So desmoglein 1 and 3, vulgaris means most common. So it will be most common. Oral lesions, skin lesions, everywhere it will be there. Okay, so desmoglein as the target. Desmoglein 1 is targeted by both foliaceus and vulgaris, and desmoglein 3 is targeted by vulgaris. So desmoglein 3 is rich in oral region, so it causes oral lesions in pemphigus vulgaris. So oral lesions are the classical of pemphigus vulgaris. Now we will see the individual things. Okay, so pemphigus foliaceus, crest and shallow erasions on the seborrheic areas, no oral lesions. This will be the no oral lesions. Blisters in superficial layer of the epidermis. So blisters are in the superficial layer of epidermis. And IgG deposits leave. Pemphigus vulgaris. So it's like flaccid blisters which is easily erode, and it in the oromucosal lesions also common. Oromucosal lesions is pemphigus vulgaris because of desmoglein 3. This is desmoglein 1, this is desmoglein 3 and 1. So 3 is in oral mucosa. Okay, clear. And here Zhang smear and histology they are getting blisters in the superficial layer of epidermis. Here acantholytic blisters formed in the suprabasal layer of the epidermis. So here it is very important, it is located in the suprabasal layer of the epidermis. Okay, so here intraepidermal and intracellular deposit of IgG, C3, fishnet appearance. We will see that immunofluorescence. Okay, so just to see these two very important. Right now we'll go to the next slide and we'll clear it. So desmoglein 1 is the target of pemphigus foliaceus, 1 and 3 vulgaris. That's why oral mucosal lesions are there. And because of acantholysis, there is something called positive Nichols sign seen. So what are the lesions which causing positive necrosis sign. You have to know by this time. What is necrosis sign? What is acantholysis? Okay, that is very important. So usually cells are like this. Okay, cells are like this. Okay, cells are like this, and it had angered by something called acanthocytes. But because these acanthocytes are managed by desmoglein, okay, desmoglein 1 3 whatever, so because of some targeted autoimmune antigen or target, these acanthocytes are damaged and there is no cell angering, and it will go to something like this. Cell will change to this shape. So this process is known as acantholysis. From the proper structure, it went like different, and this can be easily peeled off. Okay, so if I discuss, it will go to different theory class and just understand this concept. If you want in detail class, we can discuss personally, or like we can make a separate session. So at least you see here bulla spread sign and positive necrosis sign seen in pemphigus vulgaris. So from now on, pemphigus foliaceus also will come to vulgaris only. Pemphigus foliaceus means there is no oral lesions. That's all clear. And desmoglein 3 and 1 in pemphigus vulgaris, only 1 in pemphigus foliaceus. F first 1. F first 1. Remember like that. Clear? So clear. So here positive necrosis sign is there, bulla spread sign is there. So irregular angulated margins are there. You can see that. Okay, clear. And this is pemphigus foliaceus and vulgaris. Now we'll go to pemphigus bullous pemphigoid. So what is bullous pemphigoid? So this is a light, tense, itchy bulla. There is an itchy bulla with an erythematous base skin, okay, over the flexor, whatever. Here, subepidermal blisters with eosinophilic rich infiltrate. Eosinophilic rich infiltrate, subepidermal blisters. Here, subepidermal. Split is in the subepidermal. But in pemphigus vulgaris, it is suprabasal. Here, superficial layer of the epidermis in pemphigus foliaceus leaf. This will come back. Here, IgG and C3 is there. We will see that. Clear? Now, in bullous pemphigoid, you can see the bullous pemphigoid antigen 1, 2. These are their targets. It's not questioned separately. Here, then necrosis sign is negative. It is a negative. And bulla spread sign, regular round margins are there. Okay. Here, bulla spread sign may pemphigus vulgaris have irregular angulated margins. Here, regular round margins are there. Okay. Clear. Just see, it is negative necrosis sign. Now we will see the IgA, dermatitis herpetiformis. It is intensively pruritic with papulovesicles on scratching from grouped excoriations. It's like it is also a subepidermal blister with neutrophils. Okay, neutrophils with papillary tip microabscess. Okay, clear. So here it is dermatitis herpetiformis. We can see here, you can see IgA deposits over this junction, and dermal papilla and granular patterns are there. We will see that. So immunofluorescence is given each year. You can see fishnet appearance, linear appearance, granular appearance. Okay, that also we are going to discuss in a 2 minutes. So dermatitis herpetiformis, IgA, subepidermal blister, neutrophils are there, papillary tip microabscess. So I am going to give a short PAND, P4 papillary tip microabscess, A for IgA, dermatitis, D for dermatitis herpetiformis, D for dapsone also. D for dapsone, D for dermatitis herpetiformis, and N for neutrophils, A for IgA, P for papillary tip microabscess. Okay, clear. Okay, now we are already seen something in the immunofluorescence. The pemphigus vulgaris have something like fishnet appearance, and bullous pemphigoid is have granular, linear. Bullous pemphigoid have linear, and dermatitis herpetiform has granular. So this is also very important. See, you can see the lesions. This is pemphigus vulgaris and this is pemphigus vulgaris. So you can see the lesions. Oral lesions are there, pemphigus vulgaris. You can see this bulla. This is bullous pemphigoid, big bulla, bullous pemphigoid. You can see this one. This is IgA, that is dermatitis herpetiformis lesions. So pemphigus. So summarizing this is very important. Pemphigus vulgaris and foliaceous oral mucosa. Pemphigus vulgaris, it is having positive Nikodsky sign and bulla spread sign, and it is having fishnet appearance in the immunofluorescence, clear. And bullous pemphigoid, which is having linear immunofluorescence, negative Nikodsky sign, clear. Dermatitis herpetiformis, IgA, and papillary tip microabscess, neutrophils are rich, and dapsone is the drug. You can see dapsone. And here you can see the treatment different. And one more thing you have to know is this dermatitis herpetiformis IgA, which is related to HLA DQ2 and DQ8. HLA association is seen, and you can see the gluten sensitivity like celiac disease, gluten, IgA. Here same IgA, dermatitis herpetiformis, like that. Okay, so you have to avoid the bro food, barley, rye, oats, wheat, which are highly rich in gluten. So imagine a baby or a child of some 10 to 15 year old who was on completely with food of rice, suddenly started wheat or rye oats ka food, he had developed some skin lesions. Like that, it will point to dermatitis herpetiformis. Okay, and it is like granular. You can see it is granular. Linear is bullous pemphigoid, and pemphigus vulgaris is fishnet. Okay, clear. This is very important, little confusing. Even I also just explained briefly. If I explain in detail pathophysiology, like see, I started to explain the pathophysiology here. If I explain it, you will understand better. But just this is enough for your exam. Okay, time is very important. We don't want so much knowledge. We want the score. If you get so you studied so much, you got good knowledge, but your GT score is 120 out of 180. If you studied exam point of view, you got 130 correct out of 180, but you don't have that much concern. Who is better? Who is going to take better seat? Definitely the person with the more marks. So we are going for more mark, not for more concept and ideas. Okay, that's why this importance of this session is that only. If you want in detailed classes, we can take 1 hour, 2 hour elaborate class. We'll understand the concept and go. Okay, like that. Okay, now we'll go to the next topic. So this I already told. I will summarize scales in dermatology, which is very important. You can see some scales here, 1 2 3 4 figures I kept. This is very important. Scales in dermatology. Okay, this is important. So in the term will be there, you clear it, and in the view, in the image based, term based question. So brani perforaceous, brani, we already told, pityriasis versicolor, fine brani scales, pityriasis versicolor, we already told. So you can see pityriasis versicolor, fine brani scales are there. You can see this scale is looking like a silver, this silvery white scale of psoriasis. Okay, you can see here something like a fish skin. It's like fish-like, ichthyosis vulgaris, fish-like, very important. Now you can see some mycosis are there. Colorate, pityriasis rosea. So colorate means, you see here this diagram in the lesion, you can see some scales like this, colorate, like a collar. So this is seen in pityriasis rosea, and mycosis seen in pityriasis lichenoid chronica. Okay, so fine brani scales are seen in pityriasis versicolor, silvery white in psoriasis, colorate scale in pityriasis roseae, and fish-like ichthyosis, fish-like ichthyosis vulgaris. This is very important. This is nothing but ichthyosis. This is colorate scale. This is the silver scale. This is the fine brani scales in the pityriasis versicolor, variety of colors. Okay, so this is also very important. Just summarize, it will be there for your exam somewhere, one easy question. And now I am going to discuss about oxygen delivering devices. Okay, very important, and feeling it is very easy, but it will take your important 5 mark. Okay, so nothing but, see, you can see here, you can see the nasal prongs. Maybe some of you or some of us may kept nasal prongs before. Okay, so nasal prongs, it is having a flow rate of 1 to 6 liters per minute with a maximum FiO2 of 44%. Okay, so nasal prongs 1 to 6 liters of per minute, 44%. So nasal prongs, the simple one you kept in Indian ship, house urgency definitely. And you can see the simple oxygen mask, which will deliver 6 to 10 liters per minute with an FiO2 of 60 to 65%. And the most important and highly predictable question is NRBM mask. NRBM, non-rebreather mask, oxygen mask with a reservoir bag. So you can see a reservoir bag here. So it will provide 10 to 15 liters per minute with an FiO2 of 90 to 95%. This is very important. Okay, these are oxygen delivering devices with low flow variable performance with low flow with variable performance. This is low flow. These are low flow with variable performances. Okay, clear. Nasal prongs, simple oxygen mask, and NRBM. NRBM mask is very, very important. You should know that also. Now we are going. So this is low flow variable performance. Now we are going for high flow fixed performance, especially in the ICU setup. You can see this is spotter. This is a Venturi mask. Very, very important. This is spotter Venturi mask, and you can see this is nothing but HFNC. When my baby born, she was born 7th month preterm, and she was in 20th day NICU and 7 days in B. She had kept a HFNC mask and all. So I remember this. So high flow nasal cannula mask. Okay. So she used in COVID patient, flow rate 40 to 80 liters per minute can be there. And Venturi mask used in COPD, fixed oxygen. This is fixed oxygen concentration. So Venturi mask, fixed oxygen concentration. HFNC cannula, high 40 to 80 liter per minute. That much oxygen can be delivered. Okay, clear. This is also very important. And one more question, in anesthesia you do PYQ. There is some separate question for that. INICT, they regularly ask the question. Maybe NEET also it can come. We'll discuss it later also. Now very important and simple topic, and I didn't put all the nerves. You should know anatomy of the nerve, then you will understand the question. And if you don't know anatomy, it is difficult. Orthopedics also is related to nerve physiology, nerve muscle action. And here anesthesia also it is there, anatomy also. Peripheral nerve block, which is very important. It's an important part of anesthesia. Peripheral nerve block, especially in the face. Then in the hand it is see I kept hand down, and a small image I kept hand. It is very important. We know where is the radial nerve. So where is radial, where is medial nerve, where is ulnar nerve. So we know nerves in hand, leg, and all. But in the face, they will trap us in the face. They will smash our face and they will trap us in the face. So we will see what is those. See, very, very important. So you can see anterior ethmoidal block, how they are giving. See, with what point they are giving. See, very, very important. Now you can see here, this area, infraorbital nerve block. And you can see here, outside of the nase, side of the nase, external nasal block. And you can see infratrochlear here, infratrochlear nerve. Next to that, near little down only, we can see the anterior ethmoidal. Very important. So it's like little confusing. You should know the area. So you can see here, you can see infraorbital nerve I discussed. Now you see supratrochlear and supraorbital. Supraorbital little, lateral, supratrochlear. So supratrochlear, infratrochlear, supraorbital, infraorbital, external nasal, and anterior ethmoidal. They can ask any question. Okay, any question, they will point somewhere, and usually the confusing thing won't be there. If it is anterior ethmoidal and infratrochlear, it won't be there in options. At least we know infraorbital nerve where it is, supraorbital nerve where it is, supratrochlear, infratrochlear, anterior ethmoidal, and external nasal. So external nasal they'll put here and they'll ask. If you tell it is anterior ethmoidal, it's wrong. You should know where it is exactly. So you can see here supratrochlear and supraorbital. See, supratrochlear is little more here, supraorbital is here. You can see the area they are giving. So these are very, very important. Okay, to understand peripheral nerve block, especially in the face. Make a diagram if you want yourself and point it, underline and highlight it. Now we are going to see the spotters. These are very simple spotters, but these are the spotters will give you good marks. What are the spotters? Can you tell me what is this? Somebody are done C and E technique. What is this? Oh, here it is already written. These are McIntosh and Miller. What is this? Laryngoscope. Okay, we will discuss this. So what is this? Some So it is used to prevent the tongue fall during intubation. Yeah, this is Goodell's. What is this? What is this? This is, everyone know these are ET tubes. Okay, here there is some cuff. This is called cuffed ET tube. There is no cuff, uncuffed ET tube. So you have to see the diagram. So if you come to laryngoscope, you can see curved, C-shaped, curved. C, Macintosh, C is there. Miller, L-shaped, L-shaped. So it is very easy. Miller, it is L-shaped. It's used in pediatrics. And Macintosh, which is curved, C, Macintosh, that is used in adult. They can ask like this, but it's simple. They won't ask this question, preferably. But you should know. There will be this year maybe exam maybe like sentence wise. You should know curved, L-shaped. It is very important. If you do mistake, it is like you are losing a valuable 4 mark. You are losing extra 1 mark also. Please be careful. Don't go and punch your answer or click on the computer and save it and go. Just see, examiner is not a fool. They will ask a question. They will put the first option as your answer. No, definitely those the examiner is so wise. He want to filter the extra active fool students, or like they are more prone to make mistakes. He want to make them filter out. He want the toppers and very good students. So he'll put the first or 2 options, or he'll put some trap. You go, you punch it, you click on that option and you save and forward. You should read the option, and that is very important. Don't blindly mark and go. Just see, there will be a single term trapping in you. So see, curve shape. So immediately you will click on Miller. No, curve shaped Macintosh. You should know that. Okay, now we see the spotters and we'll stop the today's session. This is nothing but our anatomical face mask. Okay, so anatomical face mask, C and E technique. You know C and E technique, how to hold. You have to practice it. Triple maneuver we can use. What are the triple maneuver? Also they are regularly asking. Head tilt, chin lift, and jaw thrust. So head lift, chin lift, jaw thrust, whatever. At least jaw thrust should be there. Head tilt will be there. Chin should be lifted. Why? Proper airway. So ABCD, airway, breathing, cardia, whatever. This is nothing but Goodell's airway. See, so prevent tongue fall back. I already told, and it stimulate gag reflex. That is the side effect. Okay. So the different sized Goodell's airways are there. It is very important. What is this green color one? These are known as nasopharyngeal airway. Through the nose, they are going for putting to the trachea. Nasopharyngeal airway prevent collapse of the pharynx, no gag reflex. So if you put nasopharyngeal, there is no gag reflex, and collapse of the pharynx also can be stopped. This is also very important. Now see, I already told uncuffed ET tube and cuffed ET tube, very simple. And you can see what is boogie and stylet, which is needed to put the tube. So through the boogie or stylet, we'll put the stylet S. It is S. So you can see here it is S. So stylet here, boogie is this. Clear? They will put in ET tube intubation procedure. These are helpful things. Okay, simple only. Okay. Now we have to see something called laryngeal mask airway, LMAs. So these are LMA, laryngeal. So instead of putting the tube inside, they are just to go close the larynx there. So they have larynx here. We have device. It will close. It will provide the airway. So advantage, it is easy to use, and disadvantage is have high risk for aspiration. So whenever you are putting endotracheal tube into the trachea, it is safe. It is going to the lungs. If imagine the LMA is there, it can cause air along with that some fluid or something can go to the lungs. It causes aspiration also, risk of aspiration. So we have laryngeal LMA, laryngeal mask airway. You can see the diagram. So above esophageal sphincter, see points are there, base of the tongue. See, this is very important. And you can see one more here, Procil LMA. This is LMA, this is Procil. Modified LMA. Advantage, drain tube sucks out secretion. So there is an extra tube called a drain tube is there. So there is an extra tube called a drain tube is there, which sucks out the secretion. This is the preferred LMA because it's having an additional sucking mechanism which sucks the secretions and clear the aspiration. Risk for aspiration it reduces. Okay, that is Procil LMA, very important. Okay, you can see the diagram only, that difference you can see here. Okay, very important. So laryngeal mask airway and proceal LMA. These are two important. Now we see eye gel, second generation airway. So pilot balloon is absent here, and it's a silicon rubber grips the pharynx, and gastric drain port also present. Here gastric drain port is present. It's a second generation. Pilot balloon are absent. See, this is a spotter diagram spotter only. You should know this. Okay. There are a few more extra, but I didn't put everything. At least if you know these four, answer one or two you can eliminate. And last is slipper. Don't become slip from NEET PG preparation. Slipper, streamline linear of pharynx airway. Streamline liner of pharynx airway. You can see the image. See this image, please. Before the exam, watch it again and again and by heart this. Okay. Now we have some advanced things in this anesthesia setups. We have something called air trach. You can see air trach, video laryngoscope, and true scope. You can see images, and this is ambuscope. Okay, so very important. There are advanced things also. These are the spotters we can get from different direct question, and video based question will be there. They will put eye gel. They will show some application of eye gel or putting of eye gel, or sometime imagine they are going to put this tube video may. So this will be the potential video question also this year. Or they can ask, they can show putting of through the boogie, they are putting the ET tube. They can ask what is this, and they will show the stylet ka image, and you are marking as boogie. It is wrong. Stylet, there will be S shape. S shape will be there. Okay, it is like curved will be there. It's important. And cuffed ED tube and uncuffed. They will show the ED tube. There is no cuff will be there. The first option will be there, cuffed ED tube. Fourth option will be there, uncuffed. You are marking cuffed ED tube. You are going to get minus marks. Okay, so these are my spotters today. These are all very important spotters. Maybe today's video will be little lengthy. Watch in 720p and watch this video. This is very important video. And even I didn't put so much concepts. It is crisp and like more into exam point. That's why you feel like at least if you are feeling difficult, just watch and understand this concept. If you want PDF, please in video 3 may link of the WhatsApp channel is there. Please send request. I'll accept that. I don't want so many students. I don't want to send the PPTs or my presentation to everyone. Whoever interested, please approach. We'll share. That is definitely for sure. And I won't send for the first 24 hour. You try to watch it once. Put it like whenever free, watch. Instead of seeing PDF, watch it. And whenever you want to PDF, no, you will get confused. Better watch it in 10 minutes or 15 minutes ka session. Maximum visualize it. Okay, it will be easy for you. So these are the LMAs, spotters, ET tubes, and this anatomical face mask. These are very important spotters. Peripheral nerve block, this is also very important. And you can see the oxygen delivery device is also important. There is a potential question that we will discuss later. These are the scales in dermatology. This is very important, very important. Please see this multiple times. Immunobullous disorders, don't take into theory. Alopecia also very important. Cicatrical, non-cicatrical, scarring and non-scarring, very important. And alopecia areata, nail changes and exclamation signs, and ectothris, endothrix, very important. And Skirion Favors regularly asking question. Please see the diagrams. If you want PPT or presentation or PDF, please message. Okay, so dermatophytosis and the superficial mycosis and subcutaneous mycosis, which is very important. So today, by seeing this content analysis, what I am expecting in this coming 2026 ka NEET mein, I am expecting 4 questions fixed from this topic. 3 to 4 fixed. 4 is fixed. Maybe 5 also may come. Okay, like that. Okay, please subscribe to my channel. Put like, watch the video in your free time. Any update if you want any topic to do, please put me in comment, message in the comment. Okay, thank you so much.